Now we are going to invite Dr. Yuganki for presenting managing post-laser vision correction ectasia.
ECTASIA typically presents with progressive corneal thinning and steepening, usually inferiorly, with loss of best corrected as well as uncorrected visual acuity associated with increased myopia and irregular astigmatism. In cases where the ectasia is not progressing, it can be very well managed with bicontact lens. And as Dr. Jahangi also mentioned, that there is no cone for which a contact lens is not made. So, in mild cases of irregular astigmatism, specialty custom soft toric contact lens can also do wonders. And for advanced cases, we can use RGPs and scleral lenses. So the goals of ectasia management, the aim is first is the cessation of progression that can be achieved by corneal collagen cross-linking. And as my colleagues have already discussed the procedure, visual rehabilitation is very important in these cases since the patient was initially wanting a surgery to get rid of glasses, so they expect a good quality of vision. Contact lenses post treatment as well as intracorneal ring segments are an important tool in managing these cases. At last, the keratoplasty is the only option. Final visual rehabilitation is a combination of treatment. The goal is first to stabilize the cone and prevent the progression of keratoconus. Second is to flatten the cone and reduce the refractive error, which can be taken care using intacs or the intracorneal ring segments. And the third is to correct the refractive error, aiming emetropia. Corneal collagen cross-linking. This procedure consists of photopolymerization of the corneal stroma by combining white B2, that is a photosensitizing agent, with ultraviolet radiation. The process increases the rigidity of corneal collagen and thus reduces the likelihood of further ectasia. And like we were discussing earlier also, Dr. Dipali also mentioned that in post-LASIK eyes, it has been seen that corneal collagen cross-linking causes, more of strengthening of the tissue. And increase in the biomechanical strength of the cornea by inducing additional crosslinks between or within the collagen fibers. The procedure has already been explained. And the intracorneal ring segment act as a passive spacing agent which will flatten the cornea. They are made up of PMMA and are available by various names. The most commonly, the ones we use at our center is Intax. And the principle, as very well shown in this diagram, is that steepening or on the segment body and flattening or on and in between the segment tips. The ICRS functions by repositioning the corneal tissue, steepening the incision meridian and flattening the perpendicular one to reduce the astigmatism and higher order corneal abrasions. The normal cornea, the mechanism is that it works by shortening the arc length of the cornea, and the smaller the diameter, the greater the correction, and the amount of correction depends on the ring thickness. More thicker the ring, the more is the correction. Now the question is, the Intacs alone is not going to work in these cases. The question is that to combine Intacs with C3R, whether sequential procedure is better or a simultaneous one is the better one. CXL followed by ICRS, progression is arrested by corneal collagen cross-linking, corneal rigidity is improved, and the corneal shape is normalized by the ring segment. Mechanical flattening effect is less than predicted by ICRS that has been seen, and a delay of 6 to 8 months in visual recovery has been observed. Whereas in the simultaneous procedure, maximum mechanical flattening effect is seen and the further progression that will be arrested. It is more than a simple additive effect, so it gives a synergistic effect. That is, it is increasing the biomechanical rigidity and the pattern and distribution of collagen. It changes after the ICRS. Also, it has been seen that the areas of increased riboflavin concentration between the ICRS segments with increased collagen cross linkage. The advantages of the simultaneous procedure are that it results in rapid and predictable visual recovery. Greater improvement is seen as 1 and 3 months post-operatively, which is maintained from 6 months to 12 months, and there is no increase in haze or channel deposits. Single sitting procedure, the procedure can be completed. You don't need to call the patient twice for repeating the procedure. The challenges in cases of post-LASIK eyes is that the response can be unpredictable in some eyes. Also, we have to delineate the flap edge and the centration of the flap, and it can be difficult in cases where there are eccentric flaps. Measuring the flap thickness and planning the segment depth accordingly is an important and a crucial step. Care during insertion of the segment in the tunnel, as ICRS segment may enter a false plane between the flap and the stroma. Care to be taken not to displace the flap. And single segments, we have seen that single segments, depending upon how much is the irregularity, what is the astigmatic error, single segments also do well in few cases. And as there's the saying goes, that prevention is always better than cure, and my colleague has already touched upon the role of extra procedure combining a PRK, LASIK or SMILE with C3R in borderline cases, is we that we frequently practice at our center. And these indications have already been discussed. So to conclude, I would say that careful screening is necessary before planning a refractive surgery. Combination of strategies, ICRS with CXL, can give good results and can be customized for each case and provide a good final visual outcome. New modalities of combining CXL with laser vision correction, like we were discussing in the discussion, can be used in selected cases, although I've not seen them being practiced at my center. Thank you.
Thank you, Dr. Yuganki. So, any questions from the audience? Yes, ma'am.
I would like to know what would be the post-operative follow-up of a regular case of LASIK. So to find out if they have this post-LASIK ectasia, because as you said, without any risk factors, they may develop. So how frequently the topography needs to be done?
So, since Dr. Dipali covered the diagnosis, would you like to take this question? Yeah.
So routinely we follow up after surgery. We follow up at 1 week, then 1 month, then 3 months, then 6 months, then yearly follow up. But immediate post surgery scanning is important so that later on you can compare. If you don't do the immediate scanning, post op scanning, what I felt while making this presentation and reading all articles, no, I think 1 month. Few papers have reported 1 month. So they compare the baseline scan, then 1 month scan, and then progressive scanning whenever patient presents with a increase in myopia or astigmatism. So that can give you a clear picture.
If the 1 month scan is fine, then you review. Repeat the topo at
1 month scan will usually be fine because
fine.
patient will
3
present
months.
after maybe 1 year or
Okay.
maybe 6 months.
So
So then we investigate whenever patient is developing some problem, like whenever there is increase in astigmatism or myopia, or there is any symptom like patient is complaining of reduction in vision or poor quality.
yeah, that time
then we
would
can do. Yes.
But before that, as
Before that, we will
regular-
compare it with the 1 month post-op.
So the 1 month scan is
Ideally.
done to we have a baseline examination.
yeah.
So suppose there is a range of normalcy, right? So suppose if you have a lower normals in your elevation map, and in 3 months the patient comes with some complaint, and you have little higher normals as compared to your 1 month, so that can give you a red flag. You might not diagnose ectasia in such patient, but you know that there is something happening in the healing, or it's a healing process maybe, but the ectatic signs will not be without signs and symptoms. So patient might be having some refractive error which you might get. And one thing I do in my patient, I do contrast sensitivity as well. So many times you will feel that the quantity of vision, that is Snell's for patients reading 6 by 6, but when you compare contrast sensitivity from 1 month, 1 month anyways, lot of time contrast sensitivity is not 100% post smile or LASIK. Suppose in 3 months the contrast sensitivity is 100%. In 6 months patient is saying that my vision is not as good as it was, and then you check the Snell's is 6 by 6, but contrast is around 98%. And when you do the tomography, you see that elevations are different from the 1 month elevations. So these are the red flags which can tell you that maybe something's happening in the corneal stroma. So these are the flags we
Okay,
can look for. And the
contrast
frequent,
sensitivity, the Pelli-Robson chart, or which
yeah,
one
you can
we-
have a simple basic, because you need to compare. When the patient is normal, you don't have to go for any specialized procedure, but 100 to 97 is obviously a significant change. You should have contrast sensitivity to 100% by the 3 months of the procedure, because obviously you are dealing with stroma, and contrast sensitivities are not full usually in a month treatment. So in 3 months usually I think that my patient will have 100% contrast in everything. But if this is changing, after that, then you have to question that why it is changing. It should stay 100%, right? So these are the first sign, which are very subtle sign. Then the elevation that Dr. Dipali said, that in 1 month you take the normal map and you compare with that. If your elevations are increasing or worse than the 1 month, it should not happen, right? So these are the risk factors. So then we can have a close follow up, because nothing will happen in 3 months. For example, if the patient is a female, get pregnant, then you cannot say that 3 months is a very big time. Then we cannot predict. Male patient, non-pregnant female, no hormonal problems, you can have a close follow-up of 3 months or so and keep doing your topography. And the moment you feel that the refraction is there, astigmatism is there, elevation is there, I think LASIK post-LASIK ectasia always progresses. Keratoconus can be in stable procedure so many times, we can observe, but post-LASIK ectasia bound to progress in most of the cases. So it's better to do the surgery or do the cross-linking in such patients rather than leaving the patient and having a very thin cornea in later stages and going for the keratoplasty. So this is my opinion about
Okay.
your question.
Okay.
Yeah.
Thank you.